Hi, this is Nicole Kupchik, and welcome to Back to the Basics, Caring for the Critically Ill. This is the fourth episode in a series that I've been producing based on and really focused on caring for the moderate to severe ARDS patients as a support in the pandemic of COVID-19. In this episode, we're going to get a little more into the weeds. So we're going to talk about parameters we measure in patients who have moderate to severe ARDS. Specifically, what will we be chatting about? Peak inspiratory pressures, plateau and driving pressures. I'm going to talk about how we estimate lung compliance. And then I want to get you primed to just thinking about other rescue strategies we can use in moderate to severe ARDS, which is what I'll focus on in the next episode. So just a reminder of our case, you've got a 42-year-old patient who had progressive shortness of breath and cough for the past 2 days. She was intubated and mechanically ventilated based on just her current condition and her blood gas. She's presently on a propofol infusion getting fentanyl PRN, and they're ruling out influenza and COVID-19. Here's her x-ray, which we can all agree she's got significant bilateral pulmonary infiltrates consistent with ARDS, and these are believed to be non-cardiogenic in nature. Most recent vital signs, her heart rate's 98, which has come down kind of nicely. Her blood pressure is 124/68 with a MAP of 87. Breathing 20, which is right with the set rate on the ventilator. Her temperature is 38.1, which has come down considering what it had been. It was like almost 39 point something, so pretty significant fever. And then her SpO2 currently is 91% on 100% FiO2, but she's been having desaturation episodes. So let's dig a little deeper. Are we on the right vent settings considering her gas? And based on her gas, it looks okay-ish, right? 7.32, 56, 62, bicarbs 28, saturation 89%, and a lactate of 2.3. So the lactate has come down really nicely. But have we maximized her ventilator settings? And that's what we're going to dig a little deeper and figure out. So she's currently on assist control mode on 6 mils per kilo based on predicted body weight. So her tidal volume is 328 cc's or mils with every breath. She's on a set rate of 20 on the ventilator. She's got 12 of PEEP, and then she's still on 100% FiO2. So what are the next steps? Well, we need to dig a little deeper and just look at some of the parameters that we can measure on the ventilator. So parameters we can measure, the P to F ratio, which I talked about in the previous episode, but we'll revisit that again. Her peak inspiratory pressure, plateau or static pressure, compliance. I'm also going to talk about driving pressure. And then I'm not going to discuss it here, but another thing we can measure is something that's called auto PEEP. So let's look at our patient's values. So her P to F ratio is 62. So her PaO2 was 62, and she's on 100% FiO2. So 62 divided by 100%, move the decimal point 2 spots, divided by 1 is 62. So that's not ideal. Her peak inspiratory pressure is 43, so that's pretty elevated. Her plateau pressure is 38, that's elevated. Her driving pressure is 26, which that's pretty high. I don't want it that high. And then her compliance is 12.6, which is pretty low. So we could do some other things with the ventilator to optimize her settings. And now one of the things you have to remember is everything we measure is dynamic, and they're going to change as your patient changes. So let's dig a little deeper into what we're measuring. So first of all, peak inspiratory pressure. Our patient's was 43. And basically what peak inspiratory pressure is, it's the highest level of pressure in the lungs during inhalation. So peak inspiratory pressure increases as airway pressure and airway resistance increases. And it's a high peak inspiratory pressure can be a sign of decreased compliance in the lungs. So what are some things that will increase peak inspiratory pressure? Occlusion of your endotracheal tube or any of the tubings, bronchospasm, secretions, water in the tubings, decreased lung compliance, which I think is going to be the key here in our patient who has ARDS. Normally, you'd like to see the peak inspiratory pressure less than 30. You really should need to intervene if you don't want it to be sustained over 40. But I wouldn't look at this pressure alone. We have to look at it in conjunction with some other pressures. So another pressure we can evaluate is what's called the plateau pressure. So the way to measure this, and so first of all, what is it? It's basically the measure of, it's the pressure that's measured during no flow in the patient's airway. So to measure this, what we'll do is we'll do an inspiratory hold on the ventilator. So with me right now, do an inspiratory hold. Okay, at that point right there, we're going to get the pressure. Okay, now breathe. So we'll do an inspiratory hold on the ventilator, and at the point where no air exchange is taking place, we'll measure the pressure. Ideally, you want that less than 30 in an ARDS patient. Our patient says 38, which is pretty high. So there's some things we can do to bring that plateau pressure down. Now, driving pressure is a pressure that's calculated. Basically, it's the plateau pressure minus your patient's PEEP. Ideally, you'd like that to be less than 15. So our patient, so her plateau pressure was 38. She's on 12 a PEEP. So her driving pressure is 26. That's too high. You want to kind of narrow that gap between plateau pressure and PEEP. So there are definitely some things we can do on the ventilator to narrow that pressure. Driving pressure 26 is just way too high. Now, compliance is getting really into the weeds here, but basically, compliance is defined as a measure of the ease of expansion of your patient's lungs and thorax. And the way we calculate compliance is by taking the tidal volume in mils and dividing that by your plateau pressure minus your PEEP. So for our patient, in a normal pressure, just really quick, a normal is around 50. In an ARDS patient, we'd like to get that as high as possible. Around 50 would be ideal, but the reality is it's not going to be around 50, especially in a patient this sick. So our patient, if we kind of do the calculation, so her tidal volume is 328 mils, and we're going to divide that by her plateau pressure minus the PEEP. So her plateau pressure was 38 minus the PEEP, so 38 minus 12 is 26. So 328 divided by 26 is 12.6. And that's not good. That is a sign that her lungs have very poor compliance and are pretty stiff. So what are some clinical reasons for poor compliance? ARDS, which is our patient, pneumonia, a pneumothorax. But anytime you've got decreased compliance and stiff lungs, this value will be pretty low. All right, let's get back to our patient. So her current setting, she's on assist control mode at 6 mils per kilo, just a reminder, rate of 20, 12 a PEEP, and 100% oxygen. So her parameters, so her P to F ratio is 62. So that's not ideal. Her peak inspiratory pressure is 43. Her plateau pressure is 38. So that's pretty high. Her driving pressure is 26, which I really would like to do something about that. And then her compliance is pretty low at only 12.6. So what should we do with her ventilator settings? And I think the lowest hanging fruit would be to decrease her tidal volume and increase her PEEP. Based on her P to F ratio and just some of her other parameters, I think we can, especially her driving pressure, I really think we can maximize PEEP a little bit more. So a decision was made to increase her PEEP to 14, and we decreased her tidal volume to 5.5 mils per kg. Now, if you want to be a bit more aggressive, you could have just gone straight to 5 mils per kg, but we decided to go 5.5. So that brought her tidal volume down to 300 mils. So remember, 300 mils will go in and out of her lungs with each breath, and then her PEEP up to 14. And remember, I just want to remind you, don't forget about those predicted body weight charts that you can use. So she was on, again, she's female. Her height is 5.4. So she was on 328 mils at 6 mils per kilo. And now we're going to kind of go in between at 5.5. So that's why we chose 300, kind of like right in between. So back to the patient. So just a reminder of her new settings. So we get a gas 45 minutes later, and here's her new gas. So 731, 55, 70, 29, and 85% saturation. So she still has a primary partially compensated respiratory acidosis. Her new P to F ratio is 70. We also got some other measures on the ventilator. So her peak inspiratory pressure is 39. So that's better. That was 43. So that's a bit better. And you can see her P to F ratio is a bit improved as well. So it was 62 and now it's 70. Her plateau pressure is now 34. So remember, you do an inspiratory hold, take a deep breath, and at that point where no air exchange is taking place, her pressure is 34. So that's heading in the right direction, because remember, ideally we'd like that less than 30. Her driving pressure is down to 20. So ideally we'd like to get that less than 15, and then her compliance is up to 15. So we're heading in the right direction, but have we maximized our settings? And I would argue to say no, we probably could make a few more settings. I think we can come down on the tidal volume a bit more and go up just a bit on the PEEP. Okay, so these were our last settings. So we decided to go up to 16 on the PEEP from 14, and now we're coming down to 5 mils per kilo on the tidal volume. So that's going to give us a new tidal volume of 274 mils. So remember, that's 5 mils per kilo based on her predicted body weight. And then we bumped up her PEEP to 16. So 60 minutes later, we get a gas, and here's her new gas. So 7.3, 58, 82, 29, and 90%. And remember, a lot of those parameters we measure are dynamic. So we repeated a lot of those parameters. So her new P to F ratio is heading in the right direction. So it's 82. So remember, again, that's your PaO2 divided by your FiO2. Her peak inspiratory pressure is 37, so it's about the same, a little bit higher, but her plateau pressure is 32, so that's a little bit improved. Again, we would like that to be less than 30, ideally. And her driving pressure is 16, so again, we'd like that to be less than 15. And then her compliance has made a bit of improvement of, it's up to 16 now. So what are next steps? And, I mean, we could say let's hold. She still has a respiratory acidosis. I don't know, with a patient this sick and an x-ray that looks like it does, I would be inclined to say let's try some rescue strategies. So some other rescue strategies we can try would be proning. We can consider inhaled epoprostenol or nitric oxide would be another strategy, but proning seems to be kind of the easiest thing to go to. So with that in mind, I just want to revisit the ARDS early management guidelines, in that, just to remember, I don't want to say we've maximized our tidal volume. We could go down a little bit more, but the trade-off with that is she's going to get far more acidotic. Her plateau pressure is getting closer to 30, so we're heading in the right direction. She has a hypercapnia, which we're just going to allow, and we call that permissive hypercapnia. So we're going to allow that. As long as she doesn't have intracranial pressure issues, really, it's okay to tolerate a little bit higher PaCO2. Now, then the next steps is we can maximize PEEP. So we're on 16. We've got some room to go, but we're kind of getting up there. And I think now is the point where we should start discussing proning the patient. If she's dysynchronous with the ventilator, we might add a neuromuscular blockade in addition. And so I think we're getting to the point where we need to escalate. Now, Mass General put out this great, it's basically kind of a guide for treatment of COVID-19 patients, and they published this on March 20th. So remember, this might change as we learn more about COVID-19, but you can kind of see, if we were to do a checklist with our patient, we put her on lung protective ventilation, so we're at 5 mils per kilo right now. Her plateau pressure was still a little bit elevated, as was her driving pressure. So I honestly think we could really consider proning her. PEEP is at 16, so we've got some room. This is not a patient who you want to be dumping fluid into, especially based on her x-ray. So you want to make sure you keep her majorly on the dry side. So let's keep her dry. And, again, we can consider paralytics and inhaled epoprostenol or inhaled nitric oxide. So those are some options. So with that, I'm going to end here, And the next episode, we're going to chat about proning and some other rescue strategies. So I want to thank you for joining me. This is the 4th episode, and episode number 5 is going to be really focused on proning. All right. Thanks again for joining me. This is Nicole Kupchik, and we'll see you in episode 5.